We welcome today Dr. Hitesh Sangvi, sir. So, welcome, sir. Indeed, a pleasure and privilege to have you with us today to impart what you want to believe in nutrition. Sir is actually a surgeon practicing from 10 to 12 years. When I spoke with Sir, that Sir, we want the nutrition fraternity and clinical fraternity to understand the connect in CA and what a dietitian should actually learn from this kind of a surgery or head neck surgery because he's been specialized in it. And he said, yes, let's make the topic as identifying lacunae in nutrition management for head and neck cancer patient. Indeed, we know the management, but maybe we don't know how to identify which patient to choose for these kind of surgical options. And through a medical lens, to a surgical lens, if we know, I think it will be a great add-on knowledge to us. So thank you, sir, for accepting our knowledge. And your introduction has been very brief, as said by you. That sir is a consultant in head neck oncology. He is associated with Fortis Hospital, Mulund, Mumbai. He's been ex-fellow of Tata Memorial Hospital, ex-research associate from University of Minnesota, USA. That shows, sir, how humble you are. You don't want to spend a lot of time on introducing yourself, and it indeed speaks a lot about your personality at the same time. Thank you very much. So I now hand over the session to you without any further delay. I request participants to keep asking questions in the chat so that at the end of the session, we've kept quite some time for discussion. And we want the discussion to give us the inputs about what we are looking for in this session. Over to you, sir.
Thank you, Gitaji, and thank you, Nitin, for this opportunity to interact with you. I am not an expert in dietitian or any kind of diet or any kind of I would say a knowledge of nutrition. I'm a person who wants you people to come with me and join me to the force of treating head and neck and oral cancers. So I'm not the expert to tell you what to give, but I'm the expert to tell you where is your requirement. Okay, so today the entire lecture will be mostly on where is the lacunae, what are the gaps where you can fill in, you can help us in making the care of the cancer more comprehensive. So I am sharing the screen again. Yeah, so Gita you can help me with this. Is it shared?
Yeah, it is being shared, but yeah, it's PowerPoint mode now. Over to you, sir.
Perfect. So topic for today is identifying lacunae in nutritional management of head and neck cancer. So to be more precise, I want to find the gaps where you can fill in and make the care of the cancer more comprehensive. So to talk about head and neck cancer, oral cancer is the most common type of head and neck cancers. Oral cancer is a major health concern, ranked sixth, but for India is the first, is the most common cancer in India in males. And for females, it's breast, but for males, it is oral cancer. India has the highest capital burden with one third of the global cases, and therefore India is called global cancer capital. Around 150,000 new oral cancer cases, and half of them they die within first year of diagnosis. 74,000 casualties annually in India, and unfortunately 70% of all these incidences they are in advanced stage. So most of the patients which we see are in advanced stage, and that is the reason why it has very high death rate even after treatment. So if you see what are the etiological factors, I don't want to spend more time in explaining what is oral cancer. I'll just jump briefly, give you the overview of it, and then jump onto the nutritional aspect. So what are the etiological factors? Yesterday was a No Tobacco Day, 31st May. We had a lot of awareness campaign going on. And one of the major causes of oral cancer in India is not smoking. It is smokeless tobacco. Also, many people may not know areca nut, supari, is a class 1 carcinogen which causes oral cancer individually apart from tobacco. Alcohol has its own, it's also a class 1 carcinogen according to IARC, International Association of Research of Cancer Agency. It says that any individual who consumes alcohol has 2 times higher chances of having tongue cancers or floor of the mouth cancers. These three are etiological factors. Other two are contributory factors. Chronic mucosal trauma, because of sharp tooth or ill-fitting dentures, and poor oral hygiene also contribute to the carcinogenesis of normal mucosa. Now, we now jump on to the nutritional aspect of oral cancer. Now, very important, if you go into the literature, you understand that these three terms are used every day in and day out to understand that what is the incidence of malnutrition, cachexia, and sarcopenia. I think just to reiterate or reverberate, malnutrition is deficiency of energy proteins causing adverse effects on the body, while cachexia is more on the weight. It's involuntary weight loss characterized by anorexia and loss of fat and skeletal muscle, while sarcopenia is more on sarco means muscle, penia is less. So the loss of muscle is the focus in sarcopenia. While these three are sometimes used interchangeably in the literature, but for us, what is more important is this. So up to 80% of all the oral cavity or head neck cancer patients, they are malnutritious before they come to us in the clinic, while this number for cachexia is 40%. So when I say cachexia is weight loss of more than 5% in last 6 months, so more than 40% of all these patients are cachexic, while sarcopenic, it is more of interventional. You have to do some kind of scans, skeletal muscle scans, and etc. to understand the patient is sarcopenic or not. But even in the literature, it says almost one third of all the patients, before they come to the diagnosis, they are sarcopenic. So understand the need of the patient, that they require a buildup of nutrition even before the diagnosis. Just to give you an overview of treatment of oral cavity cancer and head neck cancers, especially in oral cavity cancers, now we have already seen that 70 to 80% of all these oral cavity cancers, they come to us in advanced stage. For advanced stage, that is stage 3 and stage 4, surgery and radiation is a multimodality treatment, sometimes in addition to chemotherapy. So majority of these patients, they will receive surgery and chemoradiation, but 80% will receive these two both. Now, problem is cancer treatment is not without its side effect. That means it also have its side effects which might come into picture later, it is early or late. Now, what are its side effects? Keeping the discussion limiting to the oral cavity and to the neck, is you will see a lot of mucositis, a lot of ulceration in the mucosa, especially after 2 to 3 weeks of radiation. Post surgery, there will be edentulism. That means there will be no teeth in the oral cavity. Therefore, the intake will automatically reduce. There are high chances of osteoradionecrosis, that means the infection of the jaw post radiation, further leading to the reduced intake of the patient. While no mouth opening or sometimes hardware structures getting exposed from the skin can all contribute to reduced oral intake even when the patient is cancer free. So, what is the pathophysiology of the patient who are cachexic or who lose their weight? Is first of all, there are 2 to 3 tumor factors. Tumor factors leads to proteolysis and lipolysis. When the tumor is there, when the cancer is there is a cytokine storm, as we have already seen sometimes in COVID. A cytokine storm happens. This cytokine storm also leads to loss of appetite and therefore loss of body weight. Body catabolism, that means the patient who has cancer has slightly high metabolic rate and therefore again loss of weight. After being all these are tumor effects of loss of weight, while radiation therapy and also surgery, because of surgery there are a lot of defects, like sometimes the patient will not have jaw, we need to remove the jaw or tongue, leading to reduced oral intake. While in radiation there will be a lot of mucositis, lot of difficulty in swallowing, dysphagia, and therefore leading to weight loss, muscle loss, or I would say even deficiency in energy. I think my slide, yeah, yeah, yeah. Now, what you have seen was of cachexia. Now, how does the mechanism in the cancer it takes place? So, if it is an early presentation, the involuntary loss is less than or equal to 5%. It is mainly because of increased proteolysis, increased lipolysis, glucose intolerance, insulin resistance, increased resting energy expenditure, which I said is increased metabolic rate. While the clinical presentation in advanced stage is muscle waste and fat loss, all leads to the BMI less than 20, weight loss greater than 5% in past 6 months, and skeletal muscular index consistent with sarcopenia, and any degree of weight loss greater than 20%. So all this leads to refractory cachexia. So when I say refractory, refractory means which does not respond to treatment. So when the once the patient enters refractory cachexia, that is where even if you build with nutrition, the patient will not have an adequate muscle fat in the body. Now, if you see, we have already discussed about all these in the previous slide, but where we can intervene is this red box, is where decreased oral intake leads to malnutrition. So it is this area where we can focus on so that the entire vicious circle is broken and we have good outcomes even after exhaustive treatment of oral or head and neck cancers. Now, why are we stressing on the improvement of nutrition? Is because the incidence of malnutrition, cachexia, or sarcopenia, it significantly impacts survival. That means if there are 100 patients who are malnutritious and there are 100 patients who are good at nutrition. For example, if you see the A figure on the left side of your screen, the green line denotes those individuals whose BMI is 18.5, sorry, greater than 24, while the black line is less than 18.5. So if you see at 100 months, there is significant difference in survival. That means almost there is 20% addition in survival of the patient if the BMI of the patient is greater than 24 at the time of treatment. Similarly, if you see cachexia on the right side of the screen, is the upper line denotes those who are not cachexic without cachexia, while the lower line denotes with cachexia, and there is a significant difference in survival of these patients over the period of 5 years. So there are a lot of indicators if you go online and if you read your books. That I'll not go into detail. A lot of indicators how you will be able to measure sarcopenia with the cutoff values. This is one of my article which in which I have tried to commemorate, or I would say conglomerate all the data available in literature. What are the cutoff values? What are the indexes used, and what are the variables used in that specific article to give you a summarized picture. Now, what are the validated nutritional assessments? So if you search literature, you will find a lot of, but you do not know what to use. So especially in cancers, subjective global assessment tool is a validated questionnaire for cancer patients. Similarly, malnutrition screening tool favorably with PGSA, that is the second one, patient generated subjective global assessment tool. The upper three are validated cancer patients, validated tool to be used for cancer patients. We all use, so for example, I use mini nutrition assessment index before the patient is taken for surgery. It will be mentioned on my OPD sheet as well. That gives me an idea on what are the complications I can expect post surgery. So, what are the nutritional parameters which we observe during our clinics? Is whether the patient has the ability to chew or swallow. What are the clinical signs of weight loss, like ill-fitting dentures or clothing? Medical history, which affects nutritional intake, like diabetes, And also the dietary history like fluid intake, reports of fullness, changes in appetite in last 24 hours. So, what are the nutritional parameters? I think this number, you all are better off than me. But just add to that to come for the completion sake is 25-35 kilocalories per day per kg per day, dependent on the activity level. While protein is somewhere between. So for cancer patients, it's somewhere between 1.2 to 2 gram per kg per day for deplete, because majority of our patients are depleted before treatment and even after treatment. And for fluid, it is 30 to 35 ml per kg per day, which increases the infection because of increase in infection and excessive fluid losses. Now, these are the parameters which we check, parameters, social parameters. I'm not going into detail. And what are the recommendations? So, I normally we follow this is we aim for energy which is at least 30 kilocalorie per kg per day, as energy requirements may be elevated post-operatively, of course, depending on the weight, and of course depending on the also on the blood loss and other components which happens in operation theater. And aims for energy and protein intake is at least 30 kilocalorie per kg per day and 1.2 gram protein per kg per day in those patients receiving radiotherapy and chemotherapy. Patients should have their weight and nutritional intake monitored regularly to determine whether the energy requirements are being met. Now, there are articles which says that we can build the patient before surgery. Now, problem with that statement is that usually when the patient comes to us, is next 2 or 3 days he's into the operation theater, because cancer is like a semi-emergency. You do not wait for a long time, but there are literature which support that starting the nutrition therapy, if the undernutrition exists for more than 7 days, enteral nutrition should be started if an inadequate food intake, at 60% of the estimated energy expenditure is anticipated for more than 10 days. Use of standard polymeric feed. Consider gastrostomy insertion if long-term feeding is necessary. Usually in head and neck and old cancer patients, we do not opt for this because usually the patient are off rice tube in 3 weeks of surgery, and if it was required, it's only for radiation period. Monitor nutrition parameters regularly throughout patient's cancer journey. I'll come to this later, where well, I have an evidence to suggest that how important is the intervention of a dietitian, intervention of a nutritional mind during treatment of cancer patient. So, what are the criterias for preoperative nutritional support? Is weight loss of 10 to 15% more than 6 months, body mass index of less than 18.5, subjective global assessment SGA of grade C, serum globulin 30 gram per deciliter, and the patient is unable to intake of more than about 60% of recommended intake for more than 7 days. So all these more than 10 days. So all these are criteria where we can think of preoperative nutrition build-up. The next topic which I want to come across is a nutritional management of these chyle leaks. Now, what happens is during surgery, uh, especially in neck, while doing neck dissections, especially on the left side of the neck, there's something called as chyle duct which comes just near to the internal jugular vein. And while dissecting the neck, all these nodes, the chyle duct is like a transparent structure which is similar to what how the nodal sheath looks, and that is the reason why sometimes the sheet of the duct gets harmed, gets nicked by the cautery, and there is a leak. Now, importance of this chyle leak, especially in nutrition management, is that there is a lot of electrolyte loss, a lot of protein loss when the chyle leak happens. Now, whenever the chyle leak happens, it will be very, I would say, peculiar in your drain. So, even for your sake, I've just clicked a photograph of a chyle leak where it looks like a milk, so it's like a milky fluid in your drain. So whenever this happens, normally we go ahead with medium chain fatty acid, MCT, because if there are any high chain fatty acids, these further increase through the chyle leaks, and which lead to the further delay in the healing of the chyle. And with chyle loss, there is a lot of protein and carbohydrate loss, and that is the reason why we need to support it nutritionally, but we cannot support it for at least 3 to 4 days till the chyle is on. That is the reason why we go for MCT, or where we do not have expertise of dietitian and nutritionist available, we'll go for fat-free diet. That becomes a ramban for us, fat-free diet. But MCT diet is always better than fat-free diet if you have expert dietitian with us, onco nutritionist with us, who will look after the patient on everyday basis. So this is very important for us, especially being a surgeon. I'll be very comfortable with a person who will look after the nutritional aspect of the patient who has chyle leaks. So to confirm the chyle leaks, there is drainage of triglyceride and chylomicron. To commence nutritional intervention with fat-free or MCT nutrition supplements, either orally, but it will be mostly while through rice tube feeding. Consider parenteral nutrition. Now, considering parenteral nutrition has its own side effects, sort of infection, is very expensive. But yes, if there is high volume of more than 1,000 or 80 ml of chyle is lost or regularly on second or third day, then we go for parenteral nutrition. We completely bypass enteral and rights to feeding and start with parenteral nutrition for at least 3 to 4 days. Observe, see if the chyle, if the volume of the chyle shrinks or decreases, and again start with we give a fat challenge to understand if the chyle persists, and if chyle persists, then we have to go in and suture. So to understand cancer cachexia, it's a multifactorial, a multimodal approach. A lot of people gets involved in this, but one of the most important people who gets involved is, of course, targeted nutrition. Now, in our hospital, what happens is there is a tumor board committee, multi-tumor board committee. Then the patient goes for surgery, and then after surgery, after 1 month, the patient goes for radiation. Radiation goes on for about 6 weeks, and then the patient is at home, and we see the patient every 3 weeks. So the usual way how the follow up or how the treatment of the old cancer proceeds. Uh, but here is a study which was done about 2 to 3 years back, where they involved a dietitian even before having problems. So there were two groups. One is the early group, where the dietitian was involved irrespective of the nutritional status of the patient, and the conventional group, where the dietitian was involved only when there were some problems with the patient, nutritional problems, or when the nutritional status of the patient deteriorated. So what was the result? So result was very, very surprising. Out of 135 patients, the prevalence of malnutrition was significantly less in early group. Almost 32% of early group had malnutrition, while 70% of the conventional group had malnutrition. And similarly, the use of dependence of nasogastric tube, also the nutrition support required post radiation, was significantly less when a dietitian was kept in loop, or I would say a nutritional unit was kept in loop even before the nutrition deteriorates. And that significantly also improved the survival of the patient. It was published in European Journal of Clinical Nutrition in 2021. So, usually how it goes is there is in our clinic, we get a nutrition assessment of every patient before the patient enters the operation theater, or any kind of chemo and radiation therapy treatment of the oral cancer starts. If he is well nourished, there will be dietetic counseling. If he is malnourished but greater than 75% of the nutritional requirement is able to have on its own, then there will be counseling plus nutrition supplements. But if it is less than 75%, he's not able to take on his own, then we might have to add nasogastric tube. Normally, we do not go for PEC tube. It is a nasogastric tube which we go, because PEC tube is another intervention, and usually these people, they come from low socioeconomic status. Now, after treatment, how this is how we follow is surgery. Then after surgery, every day our dietitian team, our nutritional team will assess. We also have a speech swallowing therapy to assess whether the patient is able to swallow on its own or not. Because only as far as the rice tube is there, we'll be able to push in the number of calories we want to push in, number of proteins we want to push in. But as soon as the rice tube is out, it is the ability of the patient to swallow and have the food per orally, which will determine the oral intake as well. Therefore, our speech swallowing therapist and dietitian, they work in tandem so that there is adequate, I would say, inflow of nutrition to the patient. So on every day, our dietitian team will see that the patient is discharged. Even discharged, they will be given a paper of written very clearly on what to take on 2 hourly basis or 3 hourly basis. While this goes on till the radiotherapy starts. So initially, in first 3 weeks of radiotherapy, normally nothing happens. The patient is in status quo mode. But after 2 to 3 weeks, all the side effects, the early effects of radiotherapy, like mucositis, reduced mouth opening, they creep in. And as soon as they creep in, there's sudden drop in the nutritional intake. If there is no Rice tube, or I would say nasogastric tube with the patient. But with constant motivation and initial training of speech swallowing and also the dialectic counseling, we may also get rid of the nasogastric tube even during radiotherapy, and the patient continues to take, I would say, normal diet. Not, I will not say normal diet, but whatever diet was normal post surgery, continues to take that even during radiation therapy period. And same goes for the chemotherapy. Chemotherapy usually in head and neck and oral cavity cancer, it is concurrent chemotherapy. That means it is given along with radiotherapy. There is no treatment post radiotherapy, especially in the curative management. Of course, the entire line of treatment for palliative chemotherapy is different. We can discuss that sometime later. But today we'll concentrate on curative management, which involves surgery and radiotherapy. So surgery, every day there is a person who sees the patient for its nutritional intake. While in radiotherapy, there's a weekly, I would say, a consultation of a dietitian, so that the nutritional assessment of the patient continues, and if there's any intervention required, it can be done on right time. So this we have seen the need a patient needs for nutrition. Now I have searched through literature, even in PubMed index journals and etc. I'm not seen the survey being done in Indian scenario. So, but this is what I got, which is a US based survey done in Ohio State, and it says that there's significant, I would say, gap in availability of a registered dietitian who has expertise in oncology, and that actually leads to the problems. I would say not only problems, it also impacts of survival of the patient over the period of time. So it has seen that only 53% of the outpatient care centers were seen by a registered dietitian. Registered dietitian were able to counsel on an average only 7 to 11 patients per day. And when I further entered and read the entire article, there was only one dietitian for 2,380 cancer patients. I think that should be multiplied by 5 or 10 times when it is in India. So that is how much we require specialized nutrition care for our cancer patients. So I want to just summarize it up. Right from, if you see this case, it is a big maxilla which we treated. We replaced it with the free anteatrial thigh flap, and he's completed disease free last next 5 years. But it is not only us which transformed him from a cancer patient to a normally living individual, but the entire team, right from the head and neck surgeons to radiation oncologists to medical oncologists to dietitians, speech following therapy, dentists. All this we work together towards making the care more comprehensive. Similarly, this patient, he had a through and through defect skin involving the buccal mucosa. If you see, we can directly see the tongue of the patient on the left side of the screen. But he survived. Yesterday, when we had this program for our cancer survivors on No Tobacco Day, he came again after 5 years, and he still works well. He's back to work. He's a key maker. So it is not only the surgeon, it's not only the radiation oncologist who have actually cured the disease. It is the dietitian, the dentist, the physiotherapist who have worked together to make their life, I would say, longer, and also to add quality of life to those survivors. So thank you very much. I end my talk with this, that there is a stringent requirement of your field, of you taking up these onus and the opportunity of I would say supporting the nutritional care and making the cancer care truly comprehensive. Thank you.
Thank you, sir. Indeed, a very important presentation to all of us, where a medical management, a surgical management highlighting the role of nutrition, which is an integral part of patient's care. And we all respect, and it's a mutual way where we really work hand in hand for patients' betterment. I invite for questions if any participant would like to talk. I think Chanchal has raised her hands up. You can unmute and talk, Chanchal. Chanchal, would you like to speak? Arpita, I think you have also raised your hand, so please unmute
Yes,
and
ma'am. Am I audible, ma'am?
yes, yes, you're very much audible.
I'm a dietitian from Malige Hospital. I practice in Bangalore right now. My question to sir is in practice, what we feel difficult is drug nutrient interaction. So, what is your idea on this, sir?
So, drug nutrient interactions, what happens is usually when we talk about oral cancer and head and neck cancer, the surgery is a prime treatment for definitive treatment for these patients. So, in head and neck and oral cancer scenario, the antibiotics and the painkillers are the only type of drugs used post surgery. So, if you're talking about chemotherapy drugs do interact with the nutrients, and that is the reason why we sometimes support it with folic acid supplements, sometimes we support it with some kind of glucosamine, etc. But as far as surgery is concerned, which is definitely treatment of oral cancer, which has only antibiotics for about 6 to 7 days, and then even the antibiotic stops, there is no documented evidence suggests that these antibiotics and painkillers they interact with major nutrients.
Interesting. But sir, I think to support that, do you feel the dietitian has to check the new drug prescription, which generally is not done by the dietitians? They're more busy planning the patient's diet. So, would you, as a medical management, would you like to say that dietitian should check the prescription and look out for multivitamins or any MVIs or B12 or folate to be given to the patient? Suppose it's not been written, then can she definitely coordinate with the team and then make it happen?
See, treatment of cancer is as I said, is a multidisciplinary team approach, and I would rather suggest that the onus of looking at treatment sheets and involving dietitians lies with us. We are responsible for telling you that please have a look that these patients are undergoing with these drugs, and you should give these kind of supplements to the patient which will help. So I would not take it on to the dietitians to tell you कि आपको change करना चाहिए. I would say it is my responsibility to tell you that yes, these patients will have some kind of nutritional or multivitamin deficiency, and therefore such kind of dietary products can be added in nutrition.
Noted, sir. Any more questions? Any more hands raised? Chanchal, I think you have raised hand, but I don't think you would like to ask anything. Would you like to? Do we have any more questions here? Okay, I really appreciated the way you showed how a nutritional assessment to screening to monitoring would take place. So here, I'll take Nabila's question once I finish asking question. You said you use many nutrition assessment tools, generally in hospitalized patient, and I would like if anybody is practicing onco nutrition in this audience to let us know what tools they use. You use mini nutrition assessment. It's generally done for geriatric patients, mostly what we have learned in literature. And we generally use subjective global assessment most of the times in hospitalized patients. So any inputs and thoughts on why you are looking at mini MNA tool and why not other tools? Anything you would like to highlight? Any research on that? Any literature?
So we have done this study here using many nutritional assessment index. Well, in all head and neck patients, we assessed through MNA and then looked on to the complication rates post surgery in 30 days period, and we found that many nutrition assessment is a very simple index. So for me, see, being a surgeon I cannot spend time in filling the entire questionnaire and forms. So what we did, and also these tools which are validated, they are according to Western world. We do not know how it works in Indian scenarios, and that is the reason why we did a study. It's an ethical approved study where we actually used MNA in head neck patients and try to relate it with the complications post surgery, also with 30 days of period. We found significant association with the MNA score, and that is the reason why it has become a practice for me. Even in my on my clinic sheet, I mentioned the MNA score of the patient.
Okay, interesting, sir. Because this is at least in my practice, I'm hearing that MNA being highlighted for onco patients. And Nabila, you've raised your hand. Would you like to comment or ask anything?
Yes. I wanted to know how effective is the multivitamin supplement in the cancer scenario, because I have heard that multivitamin supplement won't be effective in the cancer scenario, and it will be more. It is better to get a more nutrition from the food than the multivitamin supplement. Can you put your can you give something which can be effective, that multivitamin supplement should be given or not?
So in my practice, our protocol is not to give multivitamin supplements upfront. We do a assessment of the patient, and if the patient is already taking some kind of nutritional assessment, we definitely give the continuity of treatment which is already taking. But upfront giving the nutritional support, sorry, I would say multivitamin support to the patient, we usually do not do, and we do not usually follow this protocol in our hospital setting.
But in a way, sir, we don't end up meeting all the requirements of the patient through the tube feeding. The requirement is much, much higher. Patient already comes to us with a lot of cachexia and weight loss. And then going ahead surgery and getting back to normal takes some time for the patient. While balancing protein calories ratio, we don't end up balancing micronutrients. So do you feel that when we are not able to give adequate nutrition, at least a micronutrient supplement should be a part of the therapy till the patient starts meeting
Problem,
a complete full diet?
problem, yeah. So problem with these micronutrients and nutrition supplement is that there's no concrete evidence to suggest that certain type of nutrition, certain type of vitamin will work well or has any influence on the complication rates and on the survival. See, adding things, there will be a lot of things which need to be added for the treatment of the patient, because diet is one part of the treatment. There are a lot of other treatment going on in simultaneously. So what I think is, I base my treatment plan on evidence. So if there is an evidence which supports that any kind of multivitamin will support the complication rates or will reduce the complication rates and also improve survival, we'll definitely add to it.
Noted. So, there's a very interesting question coming up, and you did mention in your study, but I think you can highlight it further down. A question by dietitian Jennifer Duri says, what is the most crucial nutrition aspect to look during chemotherapy? She means the whole onco area, the chemotherapy.
So I'm not the best person to tell you because I'm a surgeon. But of course, there's a lot of nutritional problems, especially when the patient is taking chemotherapy, and especially there is a folic acid deficiency when the patient is taking cisplatin and 5-FU and docetaxel simultaneously as a three-drug regimen for our neoadjuvant chemotherapy or even in the concurrent setting. So in that scenario, then I think folic acid is the main nutrient which comes to my mind, which needs to be supported in such treatment.
So, it's folic acid or folate, sir? So, you support both.
Both.
Okay.
Support both.
Uh, Great. So, Debelina, you've raised hand. Please go ahead with your question.
Good afternoon, sir. Actually, I'm practicing in CMRI Hospital, Kolkata. I have one question. Is there any beneficial effect of glutamine for post-onco patient? Is there any benefits about glutamine?
So there are a lot of products which has glutamine, L-glutamine, and main mechanism of L-glutamine is in reducing the inflammation and in reducing the side effects of radiation. That is a mechanism of how the glutamine is supposed to work. The hypothesis is, but there is no enough evidence to support that. We are doing one small study on 30 patients who are taking L-glutamine and 30 patients who are not taking L-glutamine post surgery and who are undergoing radiation, and we are awaiting the results. But as far as literature is concerned, there is no randomized control trial. There are a lot of retrospective study. There are no randomized control trials support that yes, L-glutamine works in reducing the side effects of radiation or chemotherapy, especially in head and neck cancers.
Thank you, sir.
Interesting. Anvisha, I think you can go ahead with your question.
Yes, hello, sir. I am practicing dietitian in a hospital in Varanasi. Now, what we face
Varanasi,
as a
you mean
diet,
to say MMPC? Mahanama Pandit?
uh, no, I'm in Apex.
Apex. Okay.
Yeah. So the problem that sometimes we face is that as dietitians, we usually try to restrict sugar to the patients, but the oncologists are not on the same page regarding the sugar thing. So, what is your take on sugar? Consumption of sugar during the treatment is going on.
So, during the treatment, normally for head and neck and oral cancer patients, they're usually on RT feeds. So, are you talking about per oral sugar or through rice tube or through NG tube?
I mean, even if
Either.
we are giving blenderized diet through RT feed, so in that case, what would you suggest?
So, I have no restrictions of not giving any sugar except if the patient is diabetic or uh, there's no restriction that sugar should not be given. Of course, should be given. Uh, so every feed which we give is measured in calories, and the way of giving calories can be carbohydrate, proteins, and fats. Uh, so a component like sugar, if that contributes to the carbohydrate aspect, and if we are not able to give other food, then we can restrict it. We can restrict the sugar. But as far as only sugar is concerned, there is no restriction if you should not give sugar to the patient, because usually what the dictum or the hypothesis or the concept behind not giving sugar is that if there are any cancer cells in the body, there will be increased metabolic rate in the patient, and that will consume glucose, and that will further lead to increase in size of the cancer or spread of the cancer. But this hypothesis is still, I would say, not um, made into a proof aspect. It is still into the research.
Okay, but while doing the PET scan, don't we give the nuclear thing? We do add the glucose nuclear thing, right? So that
Yeah.
the cancer cells, to detect the cancer cells, it rushes towards the glucose. I mean the towards the glucose molecules. So don't you think
So
it?
your question is absolutely on the right track, but that is for PET scan. So what happens is PET scan is we give a radioactive dye which is labeled with glucose. That glucose is consumed by cancer cells, and then those typical cells are highlighted in on the films, or I would say on the console. But when the surgery is already done, there are no cancer cells actually in the body. So if there are no cancer cells in the body, then the consumption of the sugar will be equivalent among the cells in normal cells. And that is the reason why, especially in surgery, post surgery, there is no restriction of sugar per se. As far as diabetes is concerned, it's a different ball game. But for cancer patients, post surgery, there should not be any problems, or I would say restrictions of sugar to the patient, even in during nutrition.
Okay, so even if the patient post surgery is undergoing radiotherapy or chemotherapy.
So if the patient is operated, there is no cancer cells. I would say at least microscopically there will be some cells, but macroscopically there are no cells in the body. So in that scenario, I think sugar restriction is not a problem. Now, as far as chemo and radiation is concerned, chemo and radiation, they act when the disease is still there in the body, and the treatment takes for about 6 weeks to about 7 weeks. 7 weeks sometimes in aggressive disease, and 6 weeks in adjuvant setting. So in those scenarios as well, sometimes we restrict the sugar, but it is not completely no sugar for the patient, because if patient feels like eating, you should eat. So there's a one article I think I read in one of the journals, American Journal of Nutrition, is a way of treating is eating as treatment. So sometimes what happens is you restrict the patient with so limited diet that patient stops eating, and that should not be scenario for the patient. Patient should eat well, yes, even if that involves some part of the sugar to be involved in that, even during chemotherapy and radiotherapy.
Interesting. There's also a comment by a doctor, Devanjeet Kundu, who says I'm a clinical and radiation oncologist practicing in Kolkata, and in our practical, sorry, I can't see it. We don't practice any restriction in sugar intake for patients
Absolutely.
undergoing treatment, as there is no evidence to suggest. So,
Absolutely.
Anvesha, that means 5% of the total calories can be given as sugar, which an RDA says. It's just because we have a lot of added sugar in a normal nutrition, but otherwise, for a therapeutic nutrition, 5%, we can stick to that dictum of what the guidelines say, that sugar can be a part of your total calories. So that's, I think, we can look forward. So wonderful discussion on sugar. I invite Dr. Salome Benjamin, who's a mentor and guide of us through this session, to comment on few areas which she feels that is needed to impart. Madam, are you there? Can we have you?
Thank you, Geeta. Yes, I am there. Thank you, Dr. Sangvi, to have you on our platform, and we are grateful. Uh, yes, in between I didn't have the network or an event off, but it is definitely a very informative and illustrative explanation, and you explained it well. As an oncologist, what you expect from a nutritionist and the dietitians is rightly explained by you. And we do understand the lacuna of number of registered dietitian in our country to manage our cancer burden. It's definitely a
Need of
big
that.
concern. Yes, it's a big concern. And also about the lot of myths and knowledge, whatever you say, aptitude, which we do lack, and sometimes we get swayed away by so many things, and we do not go evidence based practice. So you rightly said we must have an evidence based practice. Or as you rightly said, sugar will increase and multiply the cancer cells, and that is why we restrict it for that particular time when the person is not under the treatment or not completely finished her radiation, chemotherapy, and the surgery treatment. What happens is, because of the reduced intake, many a times, say those dietitians who are not expert or not registered, or they will try to fill up the gap using extra sugar, and that is what we should not be doing. We should curtail it, or say definitely restrict sugar when we think of filling up the gap. We should try to give the good nutritious feed, and as per the recommendation, rightly Geeta said that 5% of RDA we can always add. There are some pediatric patients, of course, where we see that certain food will not be accepted without adding sugar. There is the time where we can use our culinary and use little sugar or other sugars like dates or other forms of to make the food sweeter, so that the patient accepts it. This is also I would like to emphasize here for the participants. Also, there is a big hype about use of milk. I would like to hear it from you, Dr. Sangvi, that some of my own oncologists, like own oncologists, I mean the patients, my patients being treated, even post radiation, post chemo, they will say this particular supplement is having milk and milk protein or a milk product, so don't take it. I think this is what we need to tell the oncologists and the clinicians, that I don't see any evidence for not giving milk or a milk product for cancer patients, and there are no evidence definitely. What is your take?
So, of course, there is no evidence, maybe because someone has not looked into it. But definitely, now I have limited experience of 10 years post my qualification, and I do come across people or having problems in, I would say, digesting, or having some kind of an acidity post milk, I would say, feed. And this is quite common, happens about 1 in 10 patients. So if you see over a period of last 1 year, if I've treated about 200 to 250 patients, I've come across 10 to 20 patients who had problems after taking milk. So milk will have some problems, I would say, gastrointestinally, but has no relation with the cancer. But yes, sometimes I have an experience that these, especially the milk product, I will not say milk in the nutritional powder, but giving raw milk to the patient will have some kind of, I would say, gastrointestinal problems, which normally settles with we giving pantoprazole and etc.
Yes, rightly said. I absolutely agree with you that, and as a nutritionist, we should not be using. And when we assess the patient, we do ask them whether there is any intolerance with milk or milk product, and how much
Absolutely.
intolerance with how much quantity. And during the treatment, yes, many of our patients do have milk intolerance or lactose intolerance, and that's why we keep it to minimum to 200 ml or 250 ml, or sometimes we avoid also in form of raw milk, as you said, and we use it as curd or any other buttermilk or other
Absolutely.
milk.
Buttermilk.
That's rightly you have said, but this is also very common among the oncologists, which we come across, and then you know that the final say is oncologist, so the patient comes back. Recently, last month only, one patient came back with the milk protein supplement, and I said, why are you returning it? She said, my oncologist said not to take. So this is what is very common among the oncologists, and it had nothing, like patient had fully recovered, patient's albumin was 1.5, and that's why the protein was increased, and the dietitian was we are looking at the nutritional status improvement, and that is why we want to add protein rich foods to the patient's diet, and when the intake is not up to the 90 plus requirement. So that's what I want to tell this the August crowd. Some of the oncologists also have joined, and the dietitians, that we should assess, and we should always practice evidence based nutrition practice. Other things about the micronutrients, what Dr. Geeta was talking, we do use some particular treatment to treat like mucositis. In my experience of so many years, like 45 plus, we do add vitamin E or zinc or selenium to treat particular complication or a side effect of the treatment, and these really do miracle when we use it in a dose. So what do you say about the same?
I think you are the best person to decide on that, because
Yes.
adding nutrients, yes, I completely rely on my dietitian to add any kind of nutrients, specifically if she's confident enough that it will work in the favor of the patient. I would never say no to that.
Thank you so much for uh, telling that to this crowd, and
Absolutely.
giving that
And
liberty to your
second,
time also to
I'm
practice.
sorry, a very important point like that, which you said, I think is a very important research topic, which I think you all having, now I can see about 70, 80 dietitian almost here on the group. I would recommend is we should do a retrospective study or even a prospective study amongst your patients on how does the patient interact with milk, because this is a very common problem we as surgical oncologists face. And as rightly said by you, that you also have an experience of many of your surgical oncologists telling you that their patients has problem with milk. I think this is a research statement which we need to address, and with you all we can definitely make it happen.
Yes, I think so. Rightly, we will consideration definitely, and go ahead with the study. Thank you, Dr. Sangvi. Geeta, over to you.
Yeah, thank you, ma'am. Indeed, very insightful inputs. I think we are done with the time, but sir, quick three pointers and questions which we have in the chat box. The oncologists definitely say, Dr. Kundu, that it's important to get the history of allergies and intolerances so we can plan diet accordingly. So every oncologist do suggest in their screening form about the history of intolerances and then give accordingly the milk or wheat or whatever we look at.
So the
Uh,
problem with this is that the incidences of problems with milk is not coherent with the incidence of lactose intolerance. So if you see, the incidence of lactose intolerance is minuscule, but the number of challenges, the number of problems which face the milk, especially milk products, post surgery is very high. So it is not completely, yes, I agree with you that if there is a lactose intolerance, then definitely will have problems and will include a dietitian as well. We also sensorize a dietitian. But then apart from patients who are having lactose intolerance, we do see these kind of patients post surgery.
Noted.
Yeah,
How about
please,
raw egg and milk and colostrum? Ma'am, you can also comment on this. Raw egg and milk for post-operative patient and colostrum.
yes, Dr. Sangvi, you want to say add anything?
I am not the best person.
Yeah, so the definitely we don't use raw egg for any whether it is cancer or no cancer. When none of us should take raw eggs
So
because
what
of
I, yeah. So what I comment is raw egg can be allergic as well.
True,
it is allergic, but it
true.
is also having it can have salmonella. So we
Absolutely.
definitely not
Absolutely.
raw egg or recommend anybody raw egg. Even raw milk, we do say pasteurized milk. But here I would add that the type of drug used for the chemo or for the patient, we must see that how that drug has compromised the patient's gut. So even if that patient was product till that day, after this course of treatment, the patient, so it's obvious that we will omit milk and product for the period when the drug is being used for the patient. So this is all part of a nutritionist or a dietitian that we will review and evaluate how the patient is on particular food, not only the milk, but we were talking as milk. Yes, yes, Geet.
Yeah, ma'am. I think we are done with questions and we have wonderful inputs, discussion. I think this was the need of the hour. We have a presentation for 40 minutes, but we talk about it, we discuss, debate, and deliberate. And what comes out of it is very basic things which dietitian wants to know about milk or about lactose. And it's very, and micronutrients and how the radiologist and a dietitian work in team because one of the dietitian had misconception about in PET scan, she came to know that sugar cannot be given. So I think it's a very basic question, and we expect that a lot of teamwork and coordination and give and thought should be done between other team. And we had very wonderful input from Salomi Madam also. So, ma'am, over to you to give any final words to the audience.
Thank you, Geeta. I think we have said almost everything we have covered. And I will say that those who are practicing in this area, they must take it as a challenge because these patients' survival is really in our hands. It's the nutritional status, the malnutrition, which is going to add into their years of life or decrease the life. It's not the cancer per se. I hope Dr. Sangvi and other oncologists are with me. So therefore, we have to maintain the nutritional status. We have to improve their nutrition intake. Sometimes we are not able to, we do continue as a tube feeding and the other support for a little longer to build up the nutritional status. But in otherwise, if you the tube is removed and the person is able to take, we'll have to find the ways how we can improve the intake and regular follow up and reassessment is very important by the nutritionists and the registered dietitians and day-to-day knowledge. I would say you must read the evidence-based in the cancer journals and other journals, the articles for pertaining to each cancer, not only to head and neck cancer, but any cancer patients you are treating, and see how you can minimize the effect of chemo, radio, and how you can maximize the nutritional status of these patients when the patients are seen by you or during the course of a disease or the treatment.
Sure, ma'am. Thank you very much. So, with that note, we conclude today's session. I thank Dr. Sangvi to have taken out time And the topic was so wonderful for us dietitians to understand what an oncology means and how do we fill in a gap there. So we look forward for your studies in collaboration with us, and so we are open to it because you are very much keen. You have assessed the MNA as a tool for your CA patient and you've published it. So we also look forward to have a teamwork with you so that the dietitians, because there are a lot of comments saying that we, in an Indian scenario, we want to know where we fail. Is micronutrients needed or is protein energy
Absolutely.
balance needed?
Those are
So,
unanswered questions we need to
yeah,
address.
so we look forward for oncologists like you to help us team up with you and treat your patients and come out with a good
So please
publication.
forward your mail ID. I'll forward you the protocol. We can start with it.
Yeah, so we definitely will look forward for more of dietitians getting in. Ma'am, you would like to say anything about the study and publishment?
Yes, I think we should be going ahead as BNA
Yeah,
Life. Also, we have a
so we look
journal and
forward.
uh,
Yeah,
support the team because this is pan India. We are doing it,
So
and those who are working in cancer hospitals and specifically in the area of head and neck cancers, if, with your protocol and your inputs and guidance, we can definitely take it forward. Thank you, Dr. Sangvi, for your support.
absolutely. So thank you very much. We would definitely look forward. And it is important that every dietitian knows that how important role she has to play there. I think if you look at the audience who have joined this session, sir, I think every time we have a very good audience joining the session, 18, 19, plus we have YouTube programming of these sessions also. So they are interested to learn, and there's a lot of learning which is happening over the thing. But what we need is expert who's actually having hands-on experience to talk about what they are going through. So thank you very much, and you gave us a perspective of what we were looking for. We look forward to have more sessions with you going ahead about your experiences, your protocols, and of course, if we work together as a team in studying the process which you're doing. Thank you very much, sir. Again, humbly grateful
definitely
to
we
your
will work
time
together.
and
And I would just add a statement where a surgical oncologist or a medical oncologist, radiation oncologist, they add years to life, but it is you who add life to those years. So thank you very much and be in loop.
with
Thank
this
you.
note, we really feel proud to be a part of the dietetic fraternity where we can contribute to so much. And definitely, Dr. Kundu, we will involve you also. Okay, any study, he says that if you are looking at study, I would like to be a part of it. There are many of us who would like to be part of it. Will definitely forward. Thank you, Salome ma'am, to be always a mentor and guide for all these sessions. Without you, nothing is impossible on BNA Live. Thank you, Nazneen and Richa, who couldn't join today, but they're always with us. Thank you, backend team, Mr. Gandhi, Advait. And last but not the least, thank you, the audience who take out time to be with us. BNA Live has a social platform, Facebook, YouTube, and Instagram. Do like it so we keep you updated with whatever happening in the field of dietetics. Practical application is what is the goal of BNA Live sessions. Thank you very much.